So welcome everyone to the bundle branch blocks lecture and lesson. And as you can see, we are rapidly approaching the end of our approach to the ECG, perhaps thankfully. Anyways, this lesson is sort of funny in that it is the one that actually has spawned the visit of the electrocardiography aspects of things, and has really kind of been the genesis of a lot of the deep dives we've done. Insofar as I got asked during these lessons to actually tackle bundle branch blocks, and for most of us, we usually we have a look, we see the cardiogram, and we recognize a right and a left bundle and what they look like. But there's always the inquisitive minds who then ask, well, why does the ECG look like that? So in this lesson, we're going to talk about bundle branch blocks, right and left, and on how to recognize them. And then for those of you who would really like to do the deep dive, we'll walk through why the QRS looks the way it does. And for those of you who probably don't care and are running out of coffee, that's fine, as long as you are able to recognize a right and a left bundle. That's what really matters. So here we are again, the electrical anatomy of the heart. And you remember in the atria we have the SA node up in the right atrium that's going to initiate our cardiac cycle. And as the atria depolarize, there's a nice pause at the SA node, or at the AV node, and that's followed by depolarization of the ventricles. That goes down the common aspect of our His-Purkinje system at the very proximal aspect there, and then rapidly divides into a right and left bundle. That right bundle takes the electrical impulse and really depolarizes the right ventricle. And the left bundle does a couple things. It actually depolarizes the interventricular septum, and you'll notice there is an anterior and a posterior fascicle to the left bundle, which basically depolarizes the anterior aspect of the heart and the posterior aspect of the heart, particularly the left ventricle, just allowing for better contraction of this ventricle, which has much more mass. So here, of course, is the left bundle branch block trouble. Basically where that X is shows where the block occurs. And so in this case, what you're going to see when the ventricle depolarizes is that the common pathway is going to start up just fine. And then the depolarization is really going to go down the right bundle pathway that you see there. And then the left ventricle is going to get depolarized basically by the current that seeps out of the right ventricle and the septum into the left ventricle. So basically what you're going to see on a ventricular depolarization is right ventricle and septum go, and then the left ventricle goes. So because of this unique way of depolarizing the left ventricle, the depolarization is not going to look normal, obviously. And hand in hand with that, of course, the repolarization of that left ventricle is going to look abnormal. And so you're going to see an ECG that looks a lot like the one you have here. The way I kind of remember these things, and we'll go over it quickly in the next slide, I guess, is that because it depolarizes the right ventricle first and then the left ventricle, you're going to get a wide QRS, meaning it's going to take more time for the ventricles to depolarize. So right off the bat, you have to have a wide QRS. And then part of my pattern recognition is just to look at lead V6 and ask myself if I see this sort of wide QRS with this notched or sloping looking QRS complex. And if so, that's probably a left bundle branch block. I then will often look over at leads 1 and AVL, because those are my lateral leads, again, looking laterally at the left ventricle. And if I see that sort of notched wide complex, then much more likely that I'm looking at a left bundle branch block. And then finally, I think we've all come to recognize that, you get this weird repolarization abnormality where if the vast majority of your QRS complex goes up, then your ST segments usually go down, and vice versa. If the vast majority of your QRS complex is facing downwards, sort of like you'd see in the anterior chest leads, sort of V1, V2, V3, then your ST segments will go upwards. So you get this sort of weird repolarization abnormality. And so that's really the signs for me that I'm looking at a left bundle for recognition. So here it basically is, and how I remember it is you're going to have a wide QRS because your right ventricle depolarizes and then your left ventricle depolarizes. When I look laterally, particularly over at lead V6, I'm going to see this notched or slurred QRS complex. And then when I think about it, how do I remember this is right or left? Is that when I put the ECG stickers on for my patients, basically V6 sits way over on the left ventricle, and because I'm seeing the trouble on the left side, it is a left bundle branch block. I don't know, it just seems to be a way it is stuck in my mind. Okay, here is the deep dive. So at this point, if you haven't done any of the electrocardiography talks earlier on, this might sound a bit like gibberish. And that's fine as long as you can recognize the left and right bundles. I'm okay with that. But if you really want to go through basically why the ECG looks the way it does, here we go. And so just a refresher to recall that you can actually get a picture of a QRS complex or any sort of electrical activity in your head by looking at kind of 3 or 4 leads really. So lead 1 is a really good picture of basically left to right. So currents, electrical currents that flow left to right across the heart are captured really well by lead 1. Lead AVF, on the other hand, captures electrical currents that are traveling upwards and downwards in that upwards and downwards direction. And then remember, leads V1 and V2 that are stuck right around the sides of the sternum, they really capture your anterior and posterior motion of electrical current, meaning from back to front, or like the patient's back to the anterior portion of their chest. So really you can get a 3-dimensional picture of what direction an electrical current is going by looking at where it's moving on these sorts of leads. And we're going to use that to describe a bit of what happens in the bundle branch blocks. Okay, this is a bit of a busy slide, but I'm going to walk you through it here. So what we look at in the very first part is what happens in the first about 10 milliseconds of ventricular depolarization. And this is really where the interventricular septum depolarizes. And when you look at your ECG leads here, it's basically that really small red underlined piece here. And so in a left bundle branch block, the left bundle isn't working. And so the normal depolarization doesn't happen the same way we get it in the left. And so the septum activates kind of from the right ventricle and across, and then spreads a little left. And the septum activates, the right ventricle activates, but the septum is a much thicker structure than the right ventricle, which is a very thin-walled structure. So a lot more of your current flow is going to happen in the interventricular septum, and that drags the mean electrical flow a bit to the left and is demonstrated by the red arrow on that beautifully drawn heart. So the way we know this is if you look at lead 1, in that first 10 milliseconds, you'll notice there's an upward deflection. So we basically know that the current has got to be traveling towards the patient's left. If we look in lead AVL, that deflection is also positive, so we know it has actually got to be traveling in a downwards direction. And then when we look at lead V1 and V2, it almost doesn't move. I mean, there's a tiny R wave in V2, but that means from a anterior-posterior direction, there's almost no electrical current moving in that direction. So really, it's kind of moving a bit right to left, and basically top to bottom, just as signified by the red arrow there. The reason I bring up lead V6 here is that I'm looking at lead V6, and that first 10 milliseconds, I mean, you have a bit of positive deflection of the QRS, and that's pretty common. So that's the very start. That's the depolarization of the interventricular septum and a bit of the RV, but it's going to get pulled left just because the septum is so much more massive than the RV. All right, so the next step, of course, is really the big depolarization, and although the right ventricle is somewhat depolarized, it is now leaking into the left ventricle, which of course is much thicker, much more massive, and really then is going to influence the amount of current that's flowing in the heart. So the sort of 20 to 60 millisecond part of our QRS complex is really reflective a lot more of left ventricular depolarization. But of course, it's depolarizing in a bit of a weird way because it's coming over from that right ventricle and from the interventricular septum. So if you look at lead 1, you see a really positive change in the QRS. So you know that the current flow has got to be flowing towards the left. And if you look at lead AVL, you'll see it is very negative. So you know that current is also flowing upwards towards the base of the heart, I guess. And then have a look at leads V1 and V2, and you'll see they're really strongly negative, which means that current flow is flowing from the anterior portion of the chest towards the back. And if you think about it, that makes sense because the left ventricle is really a posterior structure of the heart, and the activation is going to come from the right ventricle, which is more anterior, and is going to light up the left ventricle, which is more posterior. And so that current is going to be traveling basically from the patient's anterior chest area towards the posterior aspect of the left ventricle. So what you're really going to see is an arrow that looks a lot like what is diagrammed there in the red arrow on that beautifully drawn heart. And lead V6, again, this is what we look at sort of diagnostically, I suppose. And you're going to see this large positive deflection because you're really traveling, a fair amount of that electrical current is going from right to left, which is positive in lead V6. All right, so for the final 10 to 20 milliseconds, what you get is the last bit of the anterior lateral left ventricle depolarizing. And so again, this is just a continuation of the LV depolarizing, but it's that last branch of the lateral anterior aspect of the LV. And so if you look at lead 1, you'll see it still has a positive deflection, which means the current is still going towards the left, which makes sense because you're still depolarizing some of your left ventricle. In AVL, it is still negative, meaning that you're now, again, traveling in an upwards direction. And at this point in leads V1 and V2, again, still the same sort of thing where you're traveling from the anterior aspect of the chest to the posterior aspect of the chest. But that gives you basically a bit of that slurred sort of R wave that you see in lead V6. So basically, that's the 3 stages of ventricular depolarization in a left bundle. So if you really want all the ECG diagnostic criteria, here they are. And they do make sense if you work that through with those electrical vectors we just talked about. But let me sort of hit on what I think is probably the more useful 3 points here. So first of all, the QRS has to be wide in a left bundle branch block. Because the right ventricle fires normally and then the left ventricle is activated from the right, it's going to take more time to occur. It doesn't occur along the normal electrical system. And so you're going to have a wide QRS that really represents that extra time. When you look at the lateral leads, you should see that really slow extra bit of time of left ventricular depolarization, right? So your lateral leads, 1, AVL, V5 often, and V6 should have a sort of a good size R wave, and it should be broad and notched or a little sort of mini bunny rabbit ears to them. And then just to remember that because the depolarization is very weird and doesn't go by the normal electrical system, the repolarization of the heart, particularly the left ventricle, is going to also look odd. And so this means the S and T wave complexes are going to look odd and often move in a direction opposite to whatever direction the QRS goes. So that's probably the big 3 diagnostic points of a left bundle that's worth knowing. And so if you want to pause the video for a moment and have a relook at this ECG, I mean, this is a pretty representative left bundle branch block, and see if this all makes sense. All right, so you're a master of the left bundle. Let us go on to the right bundle. So as you can see by the X here in a right bundle branch block, you've lost the conduction to your right ventricle. So in this case, you're going to get activation of the left ventricle and the left bundle in a totally normal fashion. That's going to mean a couple of things. It means that by and large, the first step of ventricular depolarization is going to look quite normal, where the interventricular septum depolarizes pretty close to normal. And then you're going to get activation of the left ventricle in a pretty normal fashion. And following that, you're then going to get the delayed activation of your right ventricle. Because the left ventricle is so much more mass and larger, it means that you're going to see a little less change on your ECG, and all those weird repolarization abnormalities that we see in left bundle branch block generally don't occur in the right, because the left ventricle, which is the biggest part of the heart, is going to repolarize normally. So here we go. This is a pretty representative slide of a right bundle branch block. And there's probably two things that I use just to kind of clue in this is a right bundle. First of all, the QRS is wide. And again, this should make sense given that we're activating the left ventricle first, and then there's this delayed current that seeps over and activates the right ventricle afterwards. So it's going to take a little more time, and thus a wide QRS. And then we look for the bunny ears in leads V1 and V2. So you can see this RS-R prime complex, meaning an R wave followed by an S wave followed by an R wave that we see in V1 and V2. And that's going to be really telling that this is a right bundle branch block. So here's really just a bit of a close-up of that. So looking particularly at leads V1 and V2, first of all, they're wide, which they'll be across all the leads. There's a RS-R prime, or a notching of V1 and V2. And then I remember it just by the fact that V1 and V2, if I think about where I stick my ECG leads on, they basically are on either side of the sternum, and thus are looking at the right side of the heart. And because it's on the right side of the heart, I see this bunny rabbit ears abnormality, then I remember it is a right bundle branch block. All right, so much like in left bundle branch block, this is the deep dive into a right bundle branch block. So hold on and join in. So in the first 10 milliseconds, that very first start of ventricular depolarization, remember that the left bundle is working fine, and the left bundle is the one that actually activates the intraventricular septum. So really, that first 10 milliseconds looks almost identical to a normal QRS complex, which means you're going to get a really small Q wave in lead V1 and basically an upright bit of R wave in AVF. And so you're going to get a cardiac QRS vector in those first 10 milliseconds that looks like that red arrow that you see on the heart diagram there. So it's going a little bit away from lead V1, and it's going in the positive direction of AVF. And because it's coming from the posterior aspect of the heart towards the anterior aspect of the heart, then you're going to get an R wave in V1 and V2. So basically that's the first step of ventricular depolarization, and looks pretty much similar to what you're going to see in most QRS complexes in a normal beat. So in the next part, we get left ventricular activation. So left ventricular activation is then going to follow kind of its normal pathway. And so the QRS complex is going to have a vector that looks like the red arrow that you see here. So again, in lead 1, you're heading towards the left, so it's going to be positive. In lead AVF, you're heading downward, so it's going to be negative. And then here, it's a little different. So in V1 and V2, basically, we're now heading away, right? Because remember, the vast majority of the flow in the left ventricle is going from the anterior to the posterior aspect of the chest, and that goes away from your leads V1, V2, and thus you're going to get this S wave. So just to say that part again is, remember, activation of the left ventricle, which sits posteriorly in the chest, means the electrical conduction is going away from the chest and towards the back, and thus is going to give you an S wave in V1 and an S wave in V2. And so at the end of this QRS complex, of course, we now get the delayed activation of the right ventricle. So the right ventricle, of course, activates in a way that looks like the arrow on the diagram here. And if you look at lead 1, of course, it's going to be a bit negative as it flows towards the left, towards your patient's right, Lead AVF is going to still be a bit positive because the flow is still a bit downwards. And then V1 and V2, because you've activated the posterior aspect of the heart, right, with the left ventricle, and now it's coming forward activating the right ventricle, you suddenly are going to get this nice R wave, or the R prime wave, I should say, their second R that comes out because we're now heading back up towards the front of the chest. So V1 and V2 get this bunny-eared appearance. So here's really the interesting and useful diagnostic criteria, right? So again, QRS has to be wide. There's this RS, R prime pattern in leads V1, V2, which we think of as bunny ears or rabbit ears. And the last piece, I mean, is just sort of the kind of corollary to that is that there's a big S wave in leads 1, AVL, and 5 and 6. These, of course, are your lateral leads. And in your lateral leads, you're going to expect basically something that says, oh, there's something going on in the right ventricle and everything's flowing away from the lateral aspect of the heart. So there's going to be this negative S wave there. So really have a peek at this ECG and convince yourself that this makes sense to you. And particularly the first 2 points. Got to be wide and should have this bunny ear pattern in V1 and V2. So the good news is that is it. Just to go over again quickly the recognition. In a left bundle branch block, you need a wide QRS, and you're going to have this notched, sort of slurred R wave in V5 or V6. That's going to represent basically this sort of delayed activation of your left ventricle. And you remember it's on the left because when you put your ECG stickers on your patient, V6 sits over the left aspect of the chest and the left ventricle. On the other hand, in a right bundle branch block, you're again getting a wide QRS because of the delayed activation of the right ventricle. There is this bunny ears notching in V1 and V2. And you remember it's right because that notching is something you find over V1 and V2. And if you think of when you put your ECG leads on there, on either side of the sternum, that sits over the right side of the heart, and thus it is a right bundle branch block. So that's it, gang. We're finished the bundle branch blocks. And hopefully you've got a mastery of that. The expectation is you should be able to recognize that. And if you wanted to do a deep dive and understand exactly why the QRSs look the way they do, now you have it. And at this point, you're probably ready for some more coffee or something stronger. So we'll see you on the remaining lessons.